So our next topic of today, role of sulfonylurea in management of type 2 diabetes in view of latest national and international guidelines. You just now heard how you could benefit from usage of non-hypoglycemia causing agents. You heard how you could add vildagliptin on top of sulfonylurea and metformin. And now you would hear the position of sulfonylurea today in the management of type 2 diabetes, irrespective of the fact that you have got DPP4s, you have got vildagliptins, you have got SGLT2 inhibitors, you have now got peptide in a pill. Let us hear Dr. Rana Bhattacharya, who is MD MRCP and DM endocrinology, and he's an assistant professor in charge of hormone assay lab, Department of Endocrinology and Metabolism, IPGMER and SSKM Hospital. Received Dr. J.C. Patel and Dr. B.C. Mehta Best Paper Awards from Journal of Association of Physicians of India. Received ARCET Award from Endocrine Society of India, and more than 75 publications in peer-reviewed journals and book chapters. Over to you, Dr. Rana Bhattacharya, please.
Thank you so much. Just let me share my slide first. I hope the slides are clearly visible.
Yes, please.
Yeah. Thank you. Thank you so much, the organizers of the INDEP Summit, for inviting me here. And basically, my task is a bit difficult because, with availability of newer and newer drugs in every passing year, it's really difficult to place the various medicines to treat diabetes. On the one hand, it's a boon that so many drugs are available to treat our patient. On the other hand, it just makes the decision making more complex. Looking back, say around 20 years, then we had our metformin, the age-old drug, and along with that, again, old friends like sulfonylureas and insulins. Just gliptin just appeared on the horizon at that time. And subsequently, over the years, we have so many other drugs, both oral as well as injectable, including so many analogs of insulin. Now we have plethora of choice. But still, sulfonylurea, being kind of an age-old friend, is still useful in many patients with diabetes, and I know others will also agree that we do use this medicine on a day-to-day basis. But it's important to know how to place this drug for practical use. And we will today focus mainly on the guidelines, what the various national and international guidelines said, that's the topic that is given to me. But along with that, at least during discussion, we would focus on some practical aspects as well, taking from this guideline as well as from our personal experience with this drug, that how to use it practically in a given patient with diabetes. So this is the agenda of today's discussion. We'll just discuss a kind of overview, followed by the various global, national, regional guidelines, and we'll just look at the safety of sulfonylureas, and then how to implement sulfonylurea therapy in a patient-friendly way, and ultimately we'll discuss the position. This is something that we know very well, that with the years, the numbers of patients with diabetes are multiplying like anything. And it's when we define diabetes, there is a kind of harmonious recommendation from various world bodies regarding how to target the blood glucose levels. along with, of course, the other aspects which I won't focus today. And most of the guidelines said that fasting blood glucose level should be targeted somewhere around 80 to 130. Postprandial, if we measure it by glucometer, should be less than 180, and A1C should be less than 7. And we also know that most of the guideline also calls for individualization of the target, particularly keeping in view patients' comorbidities, very other practical concerns, and the duration of diabetes, and so on and so forth. So depending on that, most of the guidelines says that metformin possibly should be used as a first line, with some rare exceptions in some situation where metformin cannot be tolerated, or some situation where there can be extra other risks where metformin is contraindicated or other drugs are preferred. Now, if we look at the sulfonylurea, we know that as a kind of oral agent, this is one of the possibly most prescribed oral antidiabetic drug used in our country. And mechanism of action, we all know that it stimulates the release of insulin from the beta cell of the pancreas by binding with potassium ATPase channels. And there are various kinds of classification of various generations of sulfonylureas. Nowadays, we mainly classify it as first generation versus second generation. There are older generations as well, but by modern sulfonylureas, we usually mean drugs like glimepiride or gliclazide. And we all know that this sulfonylurea class of drug have a very efficacious kind of profile. Now, sulfonylurea, because of its efficacy and relatively lower cost, it was included in various lists of essential medicines across the world. But of course, there are some variation regarding which sulfonylurea is preferred over the other, particularly the difference between glimepiride and gliclazide are there depending on the country and the region. Now, if we look at the global guidelines, there are hosts of guidelines. Of course, I won't bore you with all the details of this. I will focus on few of the important points that where the sulfonylurea is placed in this guideline. Starting with the possibly the one of the most popular ones, that is American Diabetic Association, which publishes its guideline every year in the month of January. They ask to consider sulfonylurea when the patient is uncontrolled with metformin, or the target, the actual A1C is such that it's way beyond the targets, and with a single metformin, you would possibly will be unable to control the blood glucose level. So in that case, you can start with combination, and you have multiple choices. But of course, there are some specific recommendation of sulfonylureas, like when the cost is a major issue, they advised is as a second line in addition to metformin. In patients without cardiac and renal problems, they say it is preferred, but it is not contraindicated in those patients as well. And as a third line therapy in a patient who has atherosclerotic cardiovascular disease or CKD, because now we have some drugs which, in addition to glycemic control, targets the this particular organ damages. So therefore, ADA has placed sulfonylurea after such drugs like SGLT2 inhibitors or GLP-1 analogs. If we look at the recent International Diabetes Federation or IDF guideline, they said that sulfonylurea can be prescribed as a first line even when the metformin intolerance is there, but they of course ask to use the modern sulfonylureas in preference to older ones like glibenclamide. And metformin can be used as a combination of sulfonylurea. Again, they recommended the modern sulfonylureas, and they also recommend whenever you use sulfonylurea, although the modern sulfonylureas has relatively lower risk of hypoglycemia, but nonetheless, you should make the patient aware about how to recognize and self-treat hypoglycemia. So these are the recommendation from IDF. Moving over to another guideline, that is from NICE. This guideline particularly says that, again, it's NICE guideline is more or less similar to the IDF. This NICE guideline is based on UK, but the recommendations are broadly similar. They also said one additional point they have mentioned, that is a very practical one, I think. If the patient is very much symptomatic with hyperglycemia, of course we prefer insulin, but we can use sulfonylurea as well, because you know the sulfonylurea among all varieties can lower blood glucose level relatively very rapidly, and therefore for initial symptomatic management, one can use sulfonylurea either alone or preferably along with insulin, and maybe basal insulin, because with prandial insulin sometimes it's difficult to use sulfonylureas. And of course, like other guidelines, they say that it can be used as a third line after metformin plus DPP-4 inhibitors or SGLT2 inhibitors. If we look at the ISPAD guidelines, which actually looks at the it's a international body of the diabetics involving the pediatrics and adolescent age group, and they recommended that in general sulfonylurea is not approved at less than 18 years of age. But again, this is possibly true with of course with type 1 diabetes, because you know no OAD is advised there in general, but also to that some type 2 diabetes patients as well. But we have experience with sulfonylurea in our day-to-day clinical practice with a relatively rare forms of diabetes like maturity onset diabetes in young and in neonatal diabetes. So this contraindication is not blanket. In selective patient population, we use these agents in childhood and adolescence and even in the neonatal age group. Although I know you physicians won't treat neonatal hyperglycemia, neonatal diabetes, but just to make a point that this is not an absolute contraindication. WHO also said that the sulfonylurea can be used as a second line therapy when the blood glucose is not controlled with metformin. And again, WHO also stated that gliclazide and glimepiride are preferred over the older sulfonylureas because of risk of hypoglycemia. If we look at the EASD and ASE guidelines, again, they have recommended use of sulfonylurea in selective patient population. Again, possibly in most of the situation as a part of dual or triple therapy particularly. And again, in a patient with high CV and renal risk, they ask it to use it as a third line agent. Now, if we look at the various national guidelines after these international ones, but again, I won't go into details and again bore you with those. But overall, as you can see, I will just move through these slides, that across the world, sulfonylurea is still in recommendation. And in India also, the ESI RSSDI joint clinical practice recommendation, which was published 2 years back, also said that sulfonylurea can be used as a second line agent in persons who are not obese. So in non-obese type 2 diabetes, sulfonylurea can be used as a second line individual and second line agent. And of course, they also said that glimepiride and gliclazide are relatively CV safe, so they can be used in a patient with CVD. And also, they have mentioned that in DKD background, these drugs can also be used. But of course, with use of this drug if it's preferable to use self-monitoring if possible, because again, possibly due to risk of hypoglycemia. The countries in Europe and also Canada, they also recommend the use of sulfonylurea as a second or third line agent. The same is true for other countries as well. I am going to detail of this. Regarding the international task force recommendation, they said that I think these points are also mentioned in the previous guidelines, but they just summarized the whole thing in this way, that in the second generation drugs can even be used in a patient with background CVD, CKD, as well as in the elderly population, but with appropriate caution. Now, moving over to cardiovascular safety part. Now, let's see what the various guidelines say. Now, the advanced trial, this is now relatively a few years now, advanced follow-on study has also been published. This is not a kind of typical CVOT trial, because in CVOT trials, the main aim is to achieve glycemic equipoise so that the CV safety of a particular drug is tested against placebo. Although this equipoise is rarely achieved, in fact, all of the trials that have performed till date, in none of them, the equipoise was achieved. However, the advanced trial actually looked at the different things. They tried to look at the strict glycemic control with a target A1C of less than 6.5, which was achieved, versus relatively relaxed HbA1c control. And in a strict glycemic control, they have used sulfonylurea, particularly gliclazide, in the intensive arm, and there was no excess cardiovascular events in those arm, those patients who were on sulfonylurea. So it's a kind of indirect evidence, you can say, although it's not a classic CVOT. The Carolina trial, the linagliptin was compared with sulfonylurea glimepiride as a background therapy. And this is a kind of active comparator CVOT, and it showed there is non-inferior CV safety of glimepiride in comparison to linagliptin. And therefore, a meta-analysis was done of Carolina and Carmelina. Carmelina is a placebo-controlled trial of linagliptin. So the authors tried to look at whether by this indirect comparison, the sulfonylurea glimepiride, whether it can be compared with placebo in terms of cardiovascular event. And they have shown that in terms of 3-point major adverse cardiovascular outcome, all-cause mortality, CV death, and non-CV death, the glimepiride is non-inferior to placebo. Now, regarding the other age groups like elderly and in the ASCVD, CKD, heart failure population, in all those patients, second generation sulfonylurea can be used, but as I've said, with appropriate cautions. Now, if we look at from the patient's aspect, now what important factors do we look at? Number one, of course, is the comorbidities, risk of hypoglycemia, body weight of the patient, the cost of the therapy, side effects, and ultimately patient preference. Now, if we want to individualize the type 2 treatment in countries like ours, the patients, sulfonylurea can be used as a cost-effective approach, but with appropriate caution regarding weight gain and hypoglycemia. And this hypoglycemia, as I've said, can be mitigated by proper education and with appropriate up-titration of dose, whereas the weight gain, it tends to stabilize after some initial gain in weight of around 2 to 3 kgs. The continuous weight gain, which is usually seen with insulin, is not seen with sulfonylureas. And some degree of weight gain may be welcome to some of the non-obese individuals with diabetes who many a times complains that আমার খুব রোগা লাগছে, আমাকে সবাই মিলে বলছে আমি রোগা হয়ে গেছি. So in those particular situations, sulfonylurea may actually help. In patients with renal impairment, of course, you should start with relatively lower dose of modern sulfonylureas. Now, keeping these practical points in mind, I think sulfonylurea can be used safely in these susceptible populations. Even in Ramadan, there are multiple recommendations and multiple studies around the world which said that during the fasting period, if we use newer sulfonylureas, there is the adverse risks of like hypoglycemia is really not very high. And the same thing applies for elderly as well. So overall, if we look at that during in the other patient population like pregnancy, of course, this is not recommended. In children and adolescent, I've already said in type 2 diabetes is generally not recommended, but we have a plenty of experience with other kinds of diabetes in relatively young persons. In CKD, CVD, and we have already discussed. In liver disease, of course, in advanced liver disease, we should not use sulfonylurea because in advanced liver disease, the glycogen store is depleted. And if hypoglycemia occurs, it's very difficult to manage those hypoglycemia because they tend to be more severe. But with relatively milder liver impairment, like mild to moderate hepatic impairment, we can use sulfonylurea with appropriate cautions. Now, after all this, let's summarize how to position the sulfonylureas. As a monotherapy, we can use it if the insulin, if the metformin is contraindicated or not tolerated. As a second line, we can use that there is no background risk of CKD, ASCVD, heart failure, and of course, cost is a major issue, and patient does not have a very high risk of hypoglycemia. As a part of triple combination therapy, we often use this agent as it's a very efficacious one, and it can be used in addition to DPP-4, insulin, pioglitazone, and GLP-1 receptor agonist. Regarding insulin, I have said it once that it can be used with basal insulin in combination. With prandial insulin, we generally do not use it. We use it very rarely, but of course, we should use caution because it multiplies the risk of hypoglycemia if we use it with prandial insulin. And as a quadruple therapy, again, sometimes you all know we come across the patient who are very reluctant to take insulin, and you feel that patient is not very much insulinopenic. In some rare situation, you can use it as a part of quadruple combination therapy, although this is not something that we generally recommend. These can be used in some exceptional situations. In combination of insulin, we have discussed. In elderly population, we have discussed. Ramadan, CVD, we already discussed. So we use this sulfonylurea with appropriate cautions in this particular patients. To summarize, the sulfonylurea still continues to play a vital role in the management of type 2 diabetes mellitus, and the newer sulfonylureas like imipiride and gliclazide are relatively less expensive, and they have a less degree of hypoglycemia. Weight gain is also very minimal, and they do not have any cardiovascular toxicity. And majority of the trial across the world still prefer newer sulfonylureas, and they recommend continue using it, except the few situations I have said. And even in those situations, they can be used as a third line agent. So still, the countries like us, where many of the patients may not be that obese, and sometimes they need a cheap drug, and they need multiple weights sometimes. So in those situations, sulfonylurea definitely play a very important role in those patients with diabetes. Thank you all for your patient hearing. I would hand over to the organizers for further proceedings. Thank you again.
Thank you. Thank you so very much for your presentation. And just Thank you. Thank you for that wonderful presentation, reinstating the fact that we need sulfonylureas, but you have, with the cricket matches that are on, our delegates are probably in the mood of some googlies. Here comes one for you. There are certain studies which say that gliclazide has got a lesser propensity of hypoglycemia than glimepiride. Does that distinguish your use between these two agents? This is the first question. Address.
Well, yeah, there are some studies, but practically the newer antidiabetic, newer sulfonylureas as such has lesser propensity of hypoglycemia. But of course, there are some studies which say that gliclazide has a lower hypoglycemic potential. So in a patients with particularly in elderly patients or patients with renal failure, particularly, that's a subgroup where possibly we prefer gliclazide to some extent. But otherwise, both of these drugs has a lower hypoglycemic potential. The glimepiride, one of the advantage maybe the multiple doses which can be used as a up titration. So we can use a very low dose of glimepiride if the patient is very prone to hypoglycemia. So, yeah, in particular renal failure, possibly, definitely, gliclazide may be preferred.
You have already perhaps started to answer the second question, which called about the KDIGO guidelines and the use of gliclazide. And the third question, which is there, I think you take the unanswered part of the second question and the third question together. The third question is, what is the maximum dose of glimepiride that should be used in day-to-day practice?
Yes, the standard recommendation dose as per the prescribing information is 8 milligram. But we all know that beyond 3 to 4 milligram, the additional benefit is not there too much. But well, say if you see that after giving 4 milligrams, the blood glucose level is controlled, but you want a slightly better control maybe. So for this minor reduction of blood glucose, you may go on adding further doses up to 8 milligrams. But practically speaking, we very rarely use glimepiride beyond 3 or 4 milligrams. Very rarely, if at all.
Thank you. Thank you so very much for your. And there is that age-old question which always comes, which has already come from 2 or 3 of our delegates, that in a scenario where the major gliptins are likely to be off patent and available at generic price in a couple of months' time, except for linagliptin, in a scenario where we have got generic DAPA, where exactly would you start a new onset diabetic subject? What would be the patient profile where in a new onset you would prefer using a glimepiride metformin or a gliclazide metformin combination, still given the fact that 25% of the market share of combination antidiabetic is held by glimepiride metformin till date?
Yes, absolutely. A very practical question. With availability of cheaper alternatives to sulfonylureas, particularly the SGLT inhibitors and DP4 inhibitors, of course, we have a wider choice. Now, if we talk about the first line, in addition to metformin, maybe as kind of second line also, I think one of the areas where it can be used when the patient is a bit symptomatic, not very much symptomatic to begin with. There are some symptoms of hypoglycemia and you want to control blood glucose level pretty quickly. Now, other than insulin, there is no other agent that can reduce blood glucose levels so rapidly in type 2 diabetes. So in that particular situation, it can be used. Number 2, SGLT inhibitors is a kind of excellent kind of benefits, and It is also very efficacious drug, but the problem is that there are some patients where there would be contraindications and where we should use it very cautiously. So in those patient population, of course, we may use it. And again, a very practical point, many of our type 2 diabetes patients are on 3 drugs, on triple drug therapy. And some of them may be even on 4 drugs, as I've said. So in those situations, sulfonylureas still has a very important role to play. So I think practically these are the 3 areas where we may still continue using sulfonylureas.
Where before I go on to the next speaker, he talked about at the beginning. So would you not consider someone in the higher tertiles of HbA1c who was presented with perhaps an 8.59 and is unwilling to start with insulin, not really that much of osmotic symptoms?
Yes. Not really osmotic. I mean, patients with severe osmotic symptoms, there is no question.
No choice.
You must start with insulin. Yeah.
And insulin.
But in some of those patients, even as NICE guidelines actually pointed out, and practically I also in favor of in some of my patients, that initially, if we feel it's a type 2 diabetes and patient is very much symptomatic, sometimes I start with metformin along with sulfonylureas plus basal insulin. So I tend to take off basal insulin after maybe one or 1.5 months or so, and then we can modify our therapy. So this is another kind of use of this drug at the initial period, which I use. And in long run, of course, you can use along with basal insulin, as I said.
Thank you, Dr. Bhattacharya. Thank you so much for being with us and spending your time and highlighting on a nearly forgotten, not really forgotten, but going into oblivion sort of sulfonylurea from the dual pressure of newer drugs and being available at a lower price. Thank you so much. And before we go on to the next session, thank you and have a nice weekend.